or acquired immunodeficiencies, where the cause is actually outside the immune system, occur more commonly than primary immunodeficiency. So of course, when you have this patient that you're suspecting has an immunodeficiency, you'll think of the acquired causes first and then rule those out. Once you've ruled those out, then you start thinking about the primary causes. Okay, so examples of these acquired conditions include allergic inflammation. Of course, in our setting, the number one thing we'll think about is HIV infection, and then other things like immunosuppressive treatments. Other conditions that can cause acquired immunity include things that could disrupt the mucosal clearance mechanisms. So for example, patients with posterior urethral valves, this usually tend to be young boys that tend to cause some urinary obstruction. And then you get stasis of the urine. So these patients will actually present with recurrent urinary tract infections. Patients with cystic fibrosis would present with recurrent respiratory tract infections, and also they may have recurrent diarrhea. You can have disruption of the natural barrier. So remember your innate immune components, which are very important in being as the first line of defense. So eczema, especially severe eczema, with the scratches, you get disruption of the skin, burns. If there's been, for example, some sort of head injury that leads to CSF leaks, these patients may now be predisposed to infections within the central nervous system. Of course, when it comes to protein-losing enteropathies or other protein-losing conditions like nephropathies, these are patients who will generally have hypoproteinemia, and of course, with that hypoalbuminemia, they'll also have hypogammaglobulinemia. So if you have a patient who you suspect has an immune deficiency and you're getting low immunoglobulin levels, always rule out one of these protein-losing conditions. Also, conditions that affect cell metabolism, like malnutrition. They say globally malnutrition is actually the most common cause of an acquired immunodeficiency. Actually, globally would be more common than HIV/AIDS. In sub-Saharan Africa, the most common cause will be HIV/AIDS. Diabetes mellitus, patients with uremia or sickle cell anemia. And then, of course, in the medical history, you're thinking about things like drugs or treatments, which could actually cause immunodeficiency predictably. For example, if you're having a drug that causes bone marrow suppression, or it could just be an idiopathic adverse effect of the drug. So for the secondary immunodeficiencies, once you identify the cause, optimal management of the underlying condition usually would result in the immunity reverting back to normal. Okay, so we come back to evaluating patients. As I mentioned, you did a thorough and complete medical history and physical examination. And when it comes to immunological testing, a lot of these tests are actually quite sophisticated, not available in many centers. Most of them are not available locally, maybe just the screening ones, which I'll mention. But even in the West, not every hospital or every laboratory would offer some of these tests because they're very specialized. So they tend to be performed at referral centers. So usually when it comes to lab testing, initial testing is sort of limited. It will be like a screen just to help you narrow down, and you combine the results of these tests with the pertinent information from the history and physical exam to be able to guide you towards the next best test, as opposed to testing a patient for virtually anything because of the cost of the test. So once you narrow down phenotypically, so this is with information from the history and the physical exam and the initial tests, then you can now request for specific diagnostic tests. So just as an example, if you have a patient who has an increased frequency of respiratory tract infections, And from your microbiology, you're able to isolate that the bacteria are encapsulated bacteria, for example, strep pneumo, and this is a patient who has been vaccinated, for example, if it's a child, then you start thinking of either an antibody deficiency or a complement deficiency. So those are the things that you would test for. You really wouldn't start thinking of a cellular immunodeficiency or a phagocytic deficiency because you have sufficient clues from your history, your physical exam, and your initial laboratory testing. In contrast, if this was a patient who, has a history of respiratory tract infections, but the isolated organisms are fungi, for example, aspergillus, you start thinking of, remember, your immune responses to different types of pathogens. So in this case, you'd be thinking of either a phagocytic defect, okay? So either low numbers like a neutropenia or a functional defect where there's a defect in actual killing, like in chronic granulomatous disease. So I'm just going to go through a few pertinent things that should come to mind or should be sought for in the medical history. So one thing is the age. So when you're thinking about your primary immunodeficiencies, of course, a lot of them manifest in early childhood. Only the common variable immunodeficiency is likely to manifest in older patients. So pediatric patients, as long as you've ruled out the most common secondary acquired causes in a pediatric patient would either be HIV from in utero transmission or malnutrition. Okay, most of the time you don't get unless the patient has an underlying disorder like a malignancy and then they're on chemotherapy. If they don't have any of that, then most likely if they're presenting with features of an immunodeficiency, it's likely to be a primary immunodeficiency. For older patients, they're more likely to have an acquired immunodeficiency. So rule out your comorbid conditions like your metabolic conditions like diabetes or uremia or allergic inflammation. Of course, you rule out HIV. For the very elderly, you also get immunosenescence. There's a normal decline of immune responses as we age. So those are the things you'd be thinking about first. You'd want to rule out before you think of a primary immunodeficiency. So age can help you, together with the presence or absence of underlying comorbidities, can help you try and figure out what is the likely immune defect in the patient. For infants, we know that in the first year of life, or actually in early infancy, most of the immunoglobulin that they have in their serum is acquired from the mother transplacentally, and that is IgG. So if you have an infant presenting with recurrent infections from birth, soon after birth to about 3 months of age, because the IgG, the maternally acquired IgG starts waning from about 6 months of age. So those past 6 months, they have enough immunoglobulin that's coming from the mother. So during that time, if they're presenting with recurrent infections, it's most likely to be a cellular defect or a defect in the phagocytes, okay? Or complement. So those are the things you'd be thinking about, okay? The other thing to think about is the environment. So there are environmental conditions that can influence the risk of infection. So for example, if you're having a situation where, I guess this doesn't happen frequently here because we have, what's the word I want to use? Like we can afford nannies to take care of children. So like in the West where they have to have, young infants or young children in daycare facilities, they tend to be exposed to other infants who may fall ill on and off. So just in that environment, you may have the situation of recurrent infections arising. I guess the same thing would occur in our setting when children start going to school. They tend to have recurrent respiratory tract infections. It's just because of the environment. So they're transmitting to each other. And we actually even see a pattern like when schools are open versus when schools are closed. When schools are open, you have more children falling ill with recurrent respiratory tract infections as opposed to when schools are closed. Passive cigarettes, smoke inhalation in the house can also predispose to infections because the smoke is toxic to the respiratory mucosa, so induces inflammation. And, that sort of breaches the barrier that would allow for organisms to invade. Hygiene practices at home, so practices of the patient, their caregivers, and family members can have an impact, especially on things like skin infections. So sometimes it may not really be that there's an underlying immune defect, it's just that there's more exposure because of poor hygiene. For patients with allergies, exposure to indoor allergens like house dust mites and molds, especially if like they're leaky faucets or leaky piping, will worsen the allergic inflammation and increase the risk of bacterial infections in these sites. The other important thing to think of or to seek for in the history is immunization. We know that vaccines have helped to prevent especially early childhood infections within the first 5 years of life. So for children, it would be important to look at the schedule of, the vaccination cards, see that the patient has received all the recommended vaccines against preventable diseases. If they have, and this patient is presenting with infections, also think about adverse reactions to vaccines, especially the live viral vaccines. Okay, so infants who have either combined immunodeficiencies, T and B cell, or even T or B cell defects individually, are susceptible to very severe and adverse reactions to live attenuated vaccines. And these are usually contraindicated in these children. So, measles vaccine, chickenpox, rotavirus. I think I told you about a child who received, a child with kid who received the rota vaccine. It's usually given at 6 weeks. And since then, kept presenting with recurrent rota diarrhea. And then lymphadenitis caused by BCG vaccine. If it's like a mild immunodeficiency, they can just have lymphadenitis. If it's a severe one, like a SCID, this is another patient we had, they will actually present with disseminated BCGosis as opposed to BCGitis. So like the lymphadenitis would be a BCGitis, it's like localized. If it's disseminated, we call it BCGosis. Also important to ask about the past infections, because we've said this is a patient who's presenting with recurrent infection. So you'd want to know these past infections or these recurrent infections that they present, how frequent are they? What sites of the body is involved? How severe are they? Like, did they need admission or did they get treated as outpatients? Did they need oral versus parenteral antibiotics and things like that? If they require a course of antibiotics, how long did it take? Usually these patients would require longer courses, for an infection that would clear in 5 days, with 5 days of antibiotics, you're getting a patient needing like 14 days, for example. If this patient has recurrent infections that involve more than one site, you're likely to be dealing with an inborn error of immunity than an acquired cause. If they're severe and invasive infections, so remember, like I mentioned that children of school-going age, especially in the early years, tend to present with recurrent respiratory tract infections. So this would be upper respiratory tract infections. They're not deep-seated. Okay, so, your pharyngitis, tonsillitis. But if you're having a patient presenting with recurrent pneumonia, so now we're getting the lower respiratory tract involved, or recurrent otitis media, meningitis, sepsis, septic arthritis, osteomyelitis, abscesses. These are deep-seated infections. They're severe, they're invasive, they require parenteral antibiotics. Then you start thinking that this is sinister. If the microorganisms are opportunistic, those that really shouldn't cause infection in an immunocompetent individual, then you also, would also be a red flag. So things like Candida albicans or Pneumocystis jirovecii. I think I also gave you the example of the same child who had the disseminated basidiosis. The first presentation was actually just persistent oral thrush, which the initial pediatrician kept reassuring the parents. But actually, by the time they got a secondary review, this had actually involved the esophagus. So it was more like an invasive fungal infection. For patients who present with recurrent infections with capsulated bacteria, you start thinking about antibody deficiencies or complement deficiencies, because here in this case, you're thinking about the lack of opsonization. Patients with cell-mediated immune defects will present with infections with pathogens of low virulence, and there'll be all classes of pathogens. So your viruses, fungi, protozoa, and mycobacteria. So this would be similar to what we see in AIDS, okay, where you also have a cellular defect because you have no CD4 cells, basically. If the microorganisms that keep being isolated are catalase positive bacteria, you start, for example, Staph aureus, you start thinking about a phagocytic defect, and probably it could be a neutropenia, but likely to be a defect in killing. Okay, remember this catalase will break down some of the enzymes or reactive oxygen species, neutralize them, the ones that are important in killing by your phagocytes. For complement components, if it's a late complement component deficiency, C5 to C9, this patient will present with recurrent miserial infection. So the past infection, basically, aside from, site type of infection, course of treatment needed, the important aspect here would be the microbiology. If you have an individual, especially an adolescent or an adult, who's been pretty healthy all their life and then now starts presenting with recurrent or repeated infections, the first thing you think about is a secondary immunodeficiency. In our setting, first you want to rule out HIV. If that is negative, then you start thinking of, depending on the pattern of infection, that may be a common variable immunodeficiency. So this table just summarizes clues that can come from your medical history and would help you guide you as to whether this would be a cellular defect, antibody defect, a phagocytic or complement defect. I think you will look at that later. The other important aspect of the medical history is comorbid conditions. In newborns, one of the key flags would be delayed separation of the umbilical cord, falling off of the umbilical cord stump, which is just a sign of poor wound healing, and it's likely because of a neutrophil adhesion defect. So this is a patient you would want to follow up and just see how they're progressing, whether they're getting recurrent infections from that time. For patients who have the syndromic immune deficiencies, the comorbid conditions would be associated with the syndrome. For example, if it's a patient with DiGeorge syndrome, they tend to have the cardiac defects because of the lack of the parathyroid. There's a defect in calcium metabolism, so they may present with seizures because of that. It's more likely that it's the comorbid conditions that will make them present and not really the infections initially. But it's important to now, if you see a patient presenting with some of these syndromic manifestations, also think about the fact that they could have an underlying immune defect. The same thing with Wiskott-Aldrich syndrome. They tend to present with eczema and thrombocytopenia that could be symptomatic. So if you're picking this up and you think there could be a syndrome, it's important to evaluate their immunity. The other comorbid condition is atopic disease. And actually, especially for patients with who present with eczema, a lot of these primary immunodeficiencies present with eczema plus skin rashes. So that could be a sign from the medical history. Usually for patients who have other atopic conditions like allergic rhinitis and asthma, if you manage the allergic condition well, then that would help reduce, because you're reducing the inflammation in the airways, that would help reduce the frequency of infections. I mentioned your protein-losing conditions, like renal disease, for example, nephrotic syndrome, or your protein-losing enteropathies being important in an acquired cause of hypogammaglobulinemia. Other thing in the history is the use of medications, and I mentioned that the immune deficiency could be predictable. For example, if you're using a drug like rituximab, which we know is a monoclonal antibody against CD20. So this would be targeting B cells. So you want to deplete B cells in this patient. So of course, a patient who's been on a long course of rituximab will end up having an antibody deficiency. Like that goes without saying. But sometimes the immune deficiency can be because of an idiopathic effect of the drug. For example, some anticonvulsants would actually lead to a hypogammaglobulinemia, but the mechanism of that is not really known. Family history is very important, especially for primary immunodeficiencies. So here you need to inquire about history of early infant death, ask about history of consanguinity, and if you're getting a positive history of early infant death, then you need to do a family pedigree, because that will help you define a pattern of inheritance. You know, whether it's from the pedigree, you can actually be able to know whether this is X-linked, it's autosomal dominant, or autosomal recessive. This is important because many of the PIDs have X-linked inherited patterns. The other thing to think about in the family history is history of other immunological diseases like autoimmune disease or connective tissue disease, because this tells you about immune dysregulation, which is another feature of your primary immunodeficiencies. For the social history, this is very important, especially, well, I guess, I think we tend to put more emphasis in social history in pediatrics than in internal medicine, but it's important for both. So for adults, you think about, risky behavior that is associated with increased risk of acquiring HIV infection. In pediatrics, it's majorly socioeconomical factors that could be a risk for malnutrition, okay? And as I said, malnutrition is a very common cause of secondary immunodeficiency. So next is the physical examination. So clues can also come from the physical examination. A lot of time, especially if this patient doesn't have one of these syndromic conditions, like they just look like any other patient. You may not be able to pick something up unless you're very keen, or so either unless they have a syndromic condition or they've had very complicated infections with end organ damage. If it's a child with recurrent infections, especially in infancy, then they tend to have poor growth and stature, so they'll have failure to thrive. So that can give you a clue. But sometimes you'd now wonder, are they, the failure to thrive would present as malnutrition. So is it malnutrition or is it failure to thrive from the infections? Like which came first? Okay, but anyway, so you need to pay attention to detail, things like presence or absence of, the tonsillar pillars or the lymph nodes. Usually, if you don't have recurrent infection, you don't expect to palpate lymph nodes, but the tonsils, the pillar should actually be there. A lot of the time, when we're looking at examining the throat of these children, we're looking to see whether there's inflammation in the tonsils, but we don't think about how the tonsils actually there. So patients with X-linked agammaglobulinemia, because they don't have any mature B cells, usually they don't form these secondary lymphoid tissues with the germinal centers. So they'll actually not have tonsillar pillars. That's something to think about, okay? I've talked about the syndromic features, for example, chronic eczema and delayed shedding of primary teeth in hyper IgE syndrome. And then, some of the syndromes like IPEX syndrome, which would present, for example, if they're having autoimmunity involving the endocrine organs, usually it should be more than one endocrine organ. Those with neutrophil defects will tend to have chronic periodontitis. Things like, partial albinism, like silvery hair in Chiari-Higashi syndrome. I think there's also a condition called Griscelli syndrome. There was one patient who was diagnosed in Aga Khan with that, also have partial albinism. For Digestion, you're looking at the characteristic phases. So I've mentioned that for children who tend to have recurrent infections because of severe immunodeficiency, they're not going to thrive. So they're going to be small for their age. With a systemic evaluation, if you're finding diffuse lymphadenopathy or hepatosplenomegaly, you would first want to think about HIV. If that is negative, then you think about especially a lymphoproliferative disorder, which is a disorder of immune dysregulation. If there are multiple scars on the skin from recurrent skin infections, think about neutrophil defects. Patients who've had recurrent otitis media will have scarring of the tympanic membranes. So that would be a clue to think about antibody deficiencies, because most of the time these are caused by strep pneumo. And then now we come to the laboratory testing. So I mentioned initially, you start with limited testing, which would sort of like be a screen to help guide your further specialized testing. So the one test I always recommend to start with, we think it's a very routine test, but it provides a lot of information, is your complete blood count with a differential and evaluation of the peripheral blood film. So here you're looking at, your leukocyte numbers. Are they normal? Are they elevated? Is there neutropenia? Is there lymphopenia? In the film, we want to look at the morphology of these cells. Conditions like Chiari-Higashi would have like abnormal granulation of your neutrophils, for example. If there's a persistent neutrophilia and the patient is having, for example, skin infections, you're thinking about an abnormality with neutrophil transmigration. For your hemoglobin with the indices, will just tell you about chronicity of the disease. So most likely to be an anemia of chronic disease. Platelet counts are important because there are some syndromes that present with either thrombocytopenia or just abnormality in morphology where they have like a small platelet volume, so really small platelets like Wiskott-Aldrich syndrome. The important thing in the interpretation of the counts is that the reference ranges should be age-specific. For example, we know that children tend to have higher lymphocyte counts than adults. Adults tend to have more neutrophils than lymphocytes. So pay attention to the reference ranges. The other important initial test would be your chemistry, especially the liver function test. Here I'm more interested in the protein and albumin levels. And from that, you can have your calculated globulin. So low protein levels would suggest some malnutrition or a condition associated with loss of protein, which may cause hypogammaglobulinemia. So you know that the IgG is the most predominant globulin, and your total protein consists of your albumin and globulin. So IgG would be the most predominant globulin. So if you just roughly do that calculation, it can give you a clue. It's not validated here, but that has been validated in the West as a screening test for a hypogam, the calculated globulin. So anything less than 18 grams per liter, you start thinking that there are no globulins in this patient. For your liver enzymes, if they're elevated, that would just tell you maybe there's organ compromise, either because of infections that involve the liver, some form of hepatitis, or inflammation because of autoimmunity. Of course, the other important initial test in our setting is a HIV test, where you can actually just screen to look at the presence of anti-HIV antibodies. Locally, we use either ELISA or a rapid test, and I think you've gone through the principles and formats of this test. For the rapid test, usually we use 2 tier. You don't just do one and diagnose the patient. But important to think about, if a patient may have an antibody deficiency, your screening test may give a false negative. So in such a case, you may actually want to confirm with a PCR-based detection. Of course, also for children younger than 18 months of age, because they may have a false positive test because of maternal IgG if the mother is HIV positive. The other ancillary tests, which may also help to provide a clue, for example, a chest X-ray, maybe this patient has a pneumonia and you request a chest X-ray, but if it's a child, you'd also want to look at the Thymic Shadow, whether it's present or not. Under 1 year of age, it should be there. So if it's not there, you start thinking about an impaired T cell development, because it means there was nowhere for T cells to mature. Okay, we know the thymus normally involutes with age, but sometimes you may get some shrinking of the thymus in response to stresses such as severe infections or surgery or high-dose steroid treatment. I think in the autopsy series on severe acute respiratory illnesses, which involved, I think Dr. Walong was part of this series, and they are looking at causes of death among patients who present with severe acute respiratory illness. These were children less than 5 years of age. A lot of them actually had very small thymi, and he thought, okay, did they present with severe acute respiratory illness because they had these thymic defects that led to poor T cell immunity? I think maybe it's the severe infections that led to involution of the thymus. Who knows? Okay. And then, so after that, with the information that you get from your history physical exam and your initial test, you can actually have a guide or a stepwise approach to specific testing of immune function. So even with the specific testing, there are some tests that are classified as screening tests, and then they're definitive, confirmatory tests. So the screening tests are just, the aim of the screening test is, you're screening, you want to see whether there's an immunodeficiency is likely or not. And here, by the time you're coming to the specific immunological testing, you're thinking of an inborn error of immunity or a primary immunodeficiency. Because remember, for the secondary ones, you're basically trying to rule out your acquired causes. So because those are not inherent to the immune system, then you don't need to do the specific immune testing. Okay? So for the immunological testing, or when it comes to screening, you basically want to rule out the most severe primary immunodeficiencies. Okay? So if your screening tests come out positive, then now you do your confirmatory test. So as I mentioned, the confirmatory tests usually tend to be performed at a specialized lab, and you need to work with either a clinical or medical lab immunologist to help guide the interpretation of these tests. Some of them are functional tests, some of them are molecular tests, where you actually get a genetic diagnosis. Remember when we started the lecture series on your primary immunodeficiencies, I told you that there are more than 400 distinct disorders defined by more than 400 actual genetic mutations. Okay, so like the monogenic disorders. So once you confirm, your confirmation would be based on a genetic diagnosis, basically. Okay, so the first screening test would be your total serum immunoglobulin levels. Ideally, serum IgG, IgA, and IgM. IgE is not always recommended. I would only recommend an IgE if a patient, if yes, you have this patient with a suspected immune deficiency, but they're presenting with features that, from your knowledge on your basic immunology are likely to be mediated by IgE. So either they're presenting with allergic or atopic manifestations, like recurrent asthma or recurrent wheezing, rhinitis, recurrent eczema, then an IgE would be important. Okay, otherwise, if those are absent, then the IgE is not giving you much information. The reference ranges for the serum immunoglobulins need to be age adjusted as well. Okay, so even just in childhood, the range for a 1-year-old is not the same as the range for a 5-year-old. So also ensure, if you're getting results from particular labs, ensure that they're giving you age-adjusted reference ranges. When it comes to interpretation, so a hypogammaglobulinemia would be defined by an IgG level that is less than 2 standard deviations below the age-adjusted reference range, okay? So it's not just looking at the numbers, but the levels based on the standard deviation, just the basic statistics. For a gamma globulinemia, the IgG would be less than 100 milligrams per deciliter. And actually, just to note, right now, the SI unit has been changed to grams per liter. So that it matches with the proteins. Remember, for your LFTs, your protein levels and albumin are usually reported as grams per liter. So now it's been recommended that the globulins also, the immunoglobulins, be reported as grams per liter. It's only IgE that is different. It's reported as kilo international units per liter. Okay, so in all types of gamma globulinemia, you'll also get low IgA. Of course, you're getting very low IgG, IgM, IgA, but the definition is based on the level of IgG. IgA will also be low in selective IgA deficiency. And as I mentioned, for IgE, it's significant when there's underlying pathology related to IgE. For example, in hyper IgE syndrome. So in hyper IgE syndrome, these patients will have very high levels of IgE. And when I talk about very high, I'm talking about in the thousands. So in atopy, the total IgE may be in hundreds. So it's elevated, but it's not too much. In hyper IgE, as the name suggests, it's in the thousands. Okay, that's why it's called hyper. So some people also look at the immunoglobulin subclasses and majorly IgG. For IgA, it's not recommended to do your IgA1 and IgA2 levels because they've not really been associated with any specific immune defect. But for IgG, it's important. However, this is not a screening test, so it's not the first test that you perform. And you need to correlate this. So if you're doing your IgG1, IgG2, 3, and 4, it needs to be correlated with the history in terms of what specific immune defect or antibody defect this patient may have, which should correlate with basically the microbiology. And I'll just show you. So usually they confirm this with, or they follow this up with a functional antibody response to vaccination, okay, which I'll mention in the next couple of slides. So we know the function of B cells to produce antibodies. So you're screening by looking at whether this patient has any antibodies in their serum. But now you want to specifically confirm B cell function. So one screen that is, commonly available but rarely done is what we call the natural antibody screen. Natural antibodies are the isohemagglutinin, okay? The IgM we have against the carbohydrates on the red blood cells, anti-A, anti-B, okay? I'm sure you've gone through hematology and you know how these isohemagglutinin form. It's just from exposure to these cross-reactive carbohydrates in the environment, either from foods, from certain pathogens. And all individuals will have these isohemagglutinin in their serum, except those of blood type AB, because they carry both antigens. So this screen for or quantification of the isohemagglutinins can be done except in children less than 1 year old, because they don't have adequate exposure for them to form a good titer of isohemagglutinins. But generally, if they're more than 1 year old, you can screen with this and just measure the titers. So the titers should be more than 1 in 10. So if you're having low titers or absent titers, then this can give you a clue that this patient doesn't have good antibody production. The other specific B-cell functional test is looking at response to prior immunization. So you've gone through this patient's vaccination card, you see they've received immunizations. So you'd want to actually check the titers of the specific antibodies against some of these vaccines. And usually you'd want to look at a response against a protein antigen and a response against a polysaccharide antigen. Okay, so the response against a protein antigen would actually be telling you about a T-dependent response. And the important IgG subclasses that correlate with this are IgG1 and IgG3. For your polysaccharide antigens, this is giving you information of your T-independent response. And remember the specifics of your T-independent response. You don't require your germinal center, really. Okay, so most of the time you produce IgM and then maybe IgG2. Okay, so if you're not able to do your IgG subclasses, it's also quite an expensive test. Then your serum vaccination titers would help you. So a protein antigen would be, for example, your toxoids. So you're just looking at antibody levels against tetanus toxoid or diphtheria toxoid. For polysaccharide, usually we use the pneumococcal vaccine. Although now, this may be difficult to do in our setting because the pneumococcal vaccine we give to children in our schedule is the conjugated. So it's conjugated, meaning it's got the polysaccharide capsule as the antigen, but then to give a T-dependent response so that you have a long-lived response, it's conjugated usually to tetanus toxoid. So this titer may not help you much. Initially, what they used to use was the 23-valent pneumococcal vaccine, which was unconjugated. So that would be the actual polysaccharide antigen, okay? And then this is what correlates with the IgG subclasses. You can actually measure take a baseline just to see the function of your B cells in terms of IgG production. So take a baseline antibody level, and then vaccinate with a protein antigen and then a polysaccharide antigen, and then take another serum specimen just to look at the vaccine-specific titers. And for you to say there's a good vaccination response, then you should get a rise in the pre- and post-vaccination antibody titers more than 2-fold, okay? So of course, if a patient has a gamma globulinemia, you're thinking probably it's because they don't have any B cells. So you don't expect them to produce any antibody responses, okay? Those with an IgG2 subclass deficiency usually don't produce good responses against polysaccharide antigens, okay? If the patient has the other types of immunodeficiency, like a transient hypogam or a selective IgA, then they should have a normal IgG production. The next is the evaluation of cellular immunity. Usually, the screening test for this would be your delayed type hypersensitivity skin test. Remember your type 4 hypersensitivity reaction? That is what we're doing, where you're injecting a certain antigen that the patient has been exposed to previously, and then you come and look at the reaction 48 to 72 hours later. And this is usually done under the skin. And I know we know the mechanisms of the type 4 hypersensitivity. If you've forgotten, you go and revise, okay? So usually you have to use, because you're looking at response to an an antigen the patient has been exposed to previously. So you have to use an antigen the patient has been exposed to previously. In our setting, we usually use tuberculin, or the purified protein derivative, and we call this the Mantle Test because TB is endemic in our area, and ideally we've all received the BCG vaccine, so we have previous exposure. Okay, in areas where they don't have endemicity of TB, they can use tetanus toxoid mumps, Candida albicans extracts, and so forth, and then they use like the tuberculin as a negative control. So a positive test tells you there's previous exposure, one, and there's good cellular immunity, okay? If there's no response, you either think about allergy or a cellular defect. So usually this patient will be followed up with an in vitro test. So this skin test is an in vivo test because it's performed directly on the patient. If there's no response, then you want to confirm it with an in vitro test. And I'll just show you an example of that. The other test of cellular defect is the lymphocyte substrate enumeration. Although since we are quantifying the lymphocyte subsets, we'll also include the B cell. So ideally, this can also be called a screening, an immune screening test, where you just want to know, fine, you have this absolute lymphocyte count from the hemogram, but how many of these cells are actual T cells, how many are B cells, how many are NK cells? And we know, like in the peripheral blood, majority of the cells circulating are T cells. So this helps rule out, like the urgency in terms of using this as a screening test is to rule out a severe combined immunodeficiency, where the cutoff for your T cells is 300 cells per microliter. So a patient with less than 300 T cells per microliter is likely to have a SCID. And then you can quickly do your confirmatory diagnosis and make an intervention. If a patient has an antibody deficiency, then you want to know, do they have B cells? Okay. So we use flow cytometry for this. I think you've gone through the principles of flow cytometry in a different lecture. And basically, you want to detect these cells based on expression of certain markers using monoclonal antibodies. So for T cells, to enumerate the T cells, we use CD3, which is expressed by all T cells. So it's called a pan-T cell marker. And then to identify T helper cells, we use CD4. And for cytotoxic T cells, we use CD8. For B cells, you can either use CD19 or CD20. Okay. Just something I'll mention, I talked about rituximab, which is anti-CD20, causing depletion of B cells. So if you have a patient on rituximab and you want to know whether it's working, if you wanted to see, have the B cells being depleted, you're now going to use CD19 as your marker because, the patient is on an anti-CD20 marker. But generally, for a patient who's not on rituximab, you can either use CD19 or 20. For natural killer cells, we use two markers, CD16 and 56, okay? These ones are used together. For B cells, you just use one, either CD19 or CD20, okay? And just like the immunoglobulins, reference ranges are age-specific. Remember, I told you, for example, children have more lymphocytes than adults, so you can't use one reference range for all. And even in infancy, for the different ages, like 0 to 3 months, 3 to 6, the reference ranges change, okay? When it comes to interpretation, it's not just looking at the numbers. You also have to take into account other influences, for example, severe illness. Okay, so aside from age, gender, use of drugs, like steroids, I think there's a pediatrician was inquiring about doing this in a patient who's been on steroids. Of course, there'll be a lymphopenia. Okay. So severe illness, for example, it's been shown that patients who are in ICU will tend to have a transient lymphopenia. So all those things need to be taken into account when you're interpreting these results. Ideally, do your interpretation either with the clinical pathologist or the immunologist. So this is just an example just to show you how we can do a quick interpretation. So for example, here we have a scatter plot from flow cytometry with CD3 on the x-axis. So this would mark all the T cells, and CD4 should mark all the T helper cells. Okay, so a T helper cell should express both CD3 and CD4. This first box here, the A3, would be cells that are negative for CD3 and CD4. Okay, so these are not T cells, they are the lymphocytes. Okay, and cells that are positive for CD3 only would be in this A4. Those positive for CD4 only would be at A1. Okay, so this could be maybe monocytes because they're not T cells, so they're CD3 negative. So T helper cells would be on A2 because they express both CD4 and CD3. So this would be normal. And this is a patient who basically has a SCID. So they hardly have any T cells. Okay, let me not say SCID, but a T cell immunodeficiency, because you can see you not having any cells staining with CD3. You have a few CD4, but CD3 negative, which I mentioned could be monocytes, because they also express CD4. So this is just a simple diagram just to put it into context. These are other markers that I use to identify specific subsets of lymphocytes. I won't belabor you with that. And then now we have the in vitro tests for your lymphocyte function. Usually we call them proliferation assays. So here you have the lymphocytes stimulated with a mitogen. So a mitogen is a substance that would cause the cells to proliferate, induce mitosis, or an antigen. So an antigen should also do the same thing, okay? And then, so proliferation would involve DNA synthesis and cell division. So they use certain, I think radiation to be able to detect that there's proliferation, okay? So yeah, this is what we're talking about. So they incorporate here a radiolabeled nucleotide, okay? So of course, when the cells are proliferating, they'll take up these nucleotides so that they can form new DNA, okay? And usually the nucleotide they use is the tritiated thymidine. So when it's taken up, then as the cells are proliferating, they measure the uptake of the tritiated thymidine by these cells to be able to show that these cells are proliferating. Okay, and the proliferation is induced by the mitogen or antigen. So just in the same way we do the skin test, it has to be an antigen that this patient has had. If it's an antigen you're using, it's something that this patient has had previous exposure to, so that you're correlating it the same way you would the skin test. Okay, the mitogen is not really an antigen that the patient has had previous exposure to. They're just things that are known to induce mitosis of cells. So they include concanavalin A, poquid mitogen, or phytohemagglutinin. Okay, I think I'm running out of time. I'll take 5 minutes to just go through phagocytes. So for phagocytic deficiencies, usually, of course, you start with a CBC. Most common phagocyte deficiency would be neutropenia. So the CBC should tell you that. If you're finding a neutropenia in your CBC, then it's recommended that you do 2 weekly CBCs and be able to chart so that you can see if there's a cyclical pattern. Okay. There's a condition called cyclical neutropenia. So that correlates with that. So the time when there's a nadir or like a drop in the neutrophils is when the patients would present with infections. If you're having neutrophilia, very high levels of neutrophils, higher than what you get in acute infection, then you start thinking of leukocyte adhesion defect. For functional defects, either it would be, difficulty with adherence, anything that would interfere with chemotaxis of your neutrophils, or if they're able to transmigrate to a site of infection, then they're not able to kill. So here you'd be looking at neutrophil function in terms of majorly the oxidative burst. Okay, and there are 2 ways of looking at this. There's one assay that is based on flow cytometry. This is the newer assay, where they stimulate these neutrophils, and then So once they're stimulated, then they should undergo the oxidative burst, and then they should take up this substance called dihydrorhodamine, okay? And then you measure the amount of dihydrorhodamine. It's usually fluorescently labeled. So a patient who cannot produce a neutrophil burst, then you won't have any detection. I think I should have put scatter plot instead of this histogram plot. The other older version of this test is called the nitroblue tetrazolium test, where the neutrophils are stimulated, for example, with a certain antigen like lipopolysaccharide in the presence of the nitroblue tetrazolium dye. It's a yellow dye. So when these cells now become activated, they release the reactive oxygen species. The dye changes color to blue. So that is what is detected under the microscope. For your leukocyte adhesion defects, basically there's a problem with adhesion molecules that are expressed on the surface of the cell. There's a monoclonal marker against that molecule. So this can be evaluated. The cells can be evaluated for expression of these markers using flow cytometry. For complement tests, these haven't changed from what, I don't know whether we went through this in second year, but basically there's a screening test where you're looking at functional activity, either of the classical pathway or the alternative pathway. And then there are the antigen test where you're measuring actual complement components. Majorly it's C3 and C4 that are usually requested for. So the CH50 would be a screening test, which looks at the ability of the patient's serum. So complement should be in the serum, should be fresh because complement components are labile. And you're looking at the ability to lyse antibody-coated sheep red blood cells. So the antibody on the sheep red blood cells, that's an antigen-antibody complex. So it should activate the complement in the patient's serum. So you look at what, how much, basically 50% of lysis of your red blood cells, how much serum would lyse 50% of red blood cells. The same thing for the AH50. Complement deficiencies are rare. So what I just want to mention is for the early components, a defect in the early components, and I think I mentioned this in the last class, they will present with recurrent infections, but once, if it's a child, once they start producing their own antibodies, like from 1 year of age, then even if there's a complement deficiency, then they have antibody that should do the opsonizing activity. So it's rare that they'll present with recurrent infections, okay? The other thing with the complement testing, it's very finicky. When a patient has infection, you may get upregulation of, the complement production. So you may get a falsely high level. So sometimes if you get a positive test in terms of, yes, there might be a deficiency like in C3 and C4, it was recommended that you repeat it when the patient is no longer ill, okay? So most of the time, I find this test more useful for evaluation of complement activation as opposed to evaluation of deficiencies. So complement activation, I would basically be talking about our immune complex disease, okay? Yeah, I think I won't belabor you with this interpretation of complement tests. Finally, I'll just mention molecular or genetic testing. I think I already have reiterated that for the primary immunodeficiencies, these are monogenic diseases. The importance of genetic testing is so that you know exactly what disease this patient has, okay? Understand its pathology or its pathophysiology. The molecular diagnosis can help provide an avenue for targeted therapy, whether it's gene therapy or, for example, enzyme replacement therapy, provides an avenue for genetic counseling. So, for example, especially if these are patients from a consanguineous, the parents are consanguineous, the parents of the patient, then, you can provide genetic counseling so that they know what are the chances of the next child, for example, carrying such an abnormality, okay? Provides an avenue for prenatal diagnosis, prognostication as well. And then the only way we know, they keep adding to the numbers of PIDs is because of the genetic testing. 10 years ago, there were probably less than 200 PIDs, but now because of molecular techniques, we're getting more and more being defined. The preferred modality is next generation sequencing. Okay. But it's recommended that you use a targeted sequencing approach. Don't send patients for whole exome sequencing. It just shows most likely you don't even know what you're dealing. You're not taking a proper history. You don't have a good clinical phenotype. Okay. So with the targeted sequencing approach, you're using information from your history, your physical exam, and your initial screening test to assign the most likely defect so that you can actually request for the most likely genes to be sequenced. Why I'm just insisting on this is because it's going to be cheaper for the patient. So currently we're not doing this locally, but we are testing patients. We outsource to other labs who do sequencing. So this is just an example. If from your phenotype, you're thinking of B plus kid, meaning this patient has low T cells, low NK cells, but normal B cells, then these are the genes you think about. But if it's low T cells, low B cells, low NK, then you have another set of genes like the adenosine deaminase. Okay, so whole exome sequencing will just mean that you're sequencing all the exons in this patient. Of course, that comes at a more expensive cost because it's like more tests in one as opposed to a targeted approach. Other specialized tests that could be confirmatory could be biochemical tests. For example, if you're suspecting an ADA kid, you can actually measure the levels of these enzymes in red blood cells. Okay, but if a patient has been transfused recently, you use white blood cells. So if you're getting very low levels, that actually tells you that if you combine it with, for example, your lymphocyte subset, can tell you that this patient has a SCID. Finally, this is my last slide. The purpose of this slide is just to tell you that utility of flow cytometry, you can also use it. Like you can have other assays to either look at phenotype, so you're characterizing cells, or looking at function of cells. So function will be like the dihydrorhodamine assay I've shown you for the neutrophil oxidative burst. Phenotype would just be like immunophenotyping. So same thing as CD4, CD8 monitoring in HIV, the lymphocyte subset enumeration, or anything that you're doing to look at expression of a certain marker of a particular cell would be a phenotypic evaluation. Okay, just to expand the scope of flow cytometry to you, and this is just an example of the application. Okay, finally, last slide. I know I'm out of time. I'm just going to mention this as screening for SCID. So in the West, they screen for SCID. In the US, I think all states screen newborns. So this is newborn screening for SCID. I think UK is doing a pilot right now. Some of the European countries also screen every newborn. We don't in Africa, maybe because we don't think it's important. But now that we're diagnosing cases, maybe in the near future, it's something that will be considered by the government. So what they do, as I told you, SCID will be defined by a T cell count of less than 300 cells per micrometer. So as the T cells are undergoing the receptor gene rearrangement, you get some of like a small piece of DNA that gets excised from the T cell receptor gene. I'm trying to get this thing out. Let me see. Which is called, it ends up forming like a circular piece of DNA. It's called a T cell receptor excision circle. So they use PCR with primers that would anneal to this so that you get basically multiplication of the tracks. So they call it like a track analysis, T receptor excision circle. So this is what they measure. If they are low, then now you start thinking this patient may have a SCID, and then they undergo the lymphocyte subset evaluation and then the genetic testing. The blood is collected on a dried blood spot or a Guthrie card. So now you know that this card is not only for HIV PCR DNA testing in in newborns can also be used for other applications in newborn screening. Okay, we will read this conclusion. I think what I'm reiterating is that the approach, you need a thorough medical history, physical examination, and then stepwise testing. Of course, you require knowledge of your developmental pathways of your immune cells, the functions of the different compartments of the immune system, as well as clinical presentation of these disorders. I remember Harshil asking me whether you can be examined on your year 2 immunology. So yes, because if you don't know that, then you won't know any clinical immunology. I will end there. I think that's the last slide. Any questions? No questions. Okay. Have a good day.